Okay. Make it official. Okay. Welcome to the Q2 Board of Health retreat and retreat. Right. It is Tuesday, May 14th. 07. Should we do a roll call of board members? Does it matter? No, I think we're good. That's great. Retreat.
Yeah, so the first one we're going to do introductions. I know we've seen each other multiple times, but it's good just to reconnect and have some social time. So go to the next slide, Patrick. So please say your name, your pronouns, the title, and what is your why? Why are you in this work? What gives you joy? What fills your cup? So we can start with Vice President Landry.
Oh,
or Fagan. I don't know. You.
Landry Fagan, she, her, I,
Okay, your Vice President, your
day job, I work at Clinica. I love working with the underserved, and I came to this work with the hope of better integrating what happens at FQHCs and what public health does, so that we are supporting each other and not duplicating, and also forwarding the same population of people to services that need services in both locations. And I actually learned about this whole position and everything because of the Genesis program, because I met representatives from the Genesis program with patients at that salute. So, yeah. Hi, Morgan McMillan, she, her. Day job is that I run a small climate-focused foundation that does work nationally. And prior to that, I worked for a long time, close to 20 years, for the community foundation locally. So I worked for a long time with the nonprofit community here and the local government. I'm a huge believer in the power of local, and also really interested in social determinants of health. That's what my passion area around public health is. So, I'm so happy to be with you all. No, I do mean that. I do mean that, not just in this moment, since we were here last night too, but actually I really appreciate the expertise and the passion of this staff. That was not meant to sound sarcastic.
I think you're finishing up your 5th year. Morgan's starting this year 6th.
Yeah.
Yes. Yes.
Thank you. I am Amber Johnson. I use she, her pronouns. I am the newest board member. I think my year is October. October 1 is your. And my day job is I work as the director of quality improvement for the state's perinatal quality collaborative, and I run the hospital-based quality improvement programs for labor treatments for substance use and cesarean reduction. And my night job is that I still practice as a nurse midwife in dental health when I do that, and the obstetric ED, labor and delivery, postpartum aesthetics. And I'm here because I really am passionate about reproductive health care, and the deeper I get into it, the more I realize that it's also a public health issue, that sort of that extra ecosystem that needs to impact reproductive health.
Jordan Thomas, I use she, her pronouns. I'm the business operations manager and board of health liaison. Let's see, what is my why? So I think my why is probably staying the same. I really love just like logistics and government. I grew up with my family not having a lot of trust in local government, but seeing how they could have benefited from local government programs. So when I went home this past week, I got to tell them about all the really cool things I get to do. And they were like, oh, that would have been helpful. I'm like, yes, it would. So kind of going that route and like just reaffirming that we are doing good regardless of the stereotypes that local government has. It makes me really happy to figure out puzzles, solutions. So.
Yeah, Patrick Cannell, he, him, administrative assistant. And my why is, after a long career in the private sector, I really wanted to do something that made more of a difference and was local. So I just moved here in 2020 during the pandemic. I'm one of them, although I moved from Minnesota, so it's, you kind of get a break.
Are you looking for a pass?
Not Texas or California.
Easy.
I am from Texas, though. I went to Texas A&M, if that matters anybody. So, but yeah, that's my why. So I wanted to do something meaningful, impactful in the local community.
Great, I use theirs. I'm the community health division manager. My why, I think professionally, most of my schooling and training is in social work and social change, which is how I ended up in community health. I'm really interested in all of the social determinants that impact health. My main focus is around equity. As someone who came out in the Deep South and has navigated all that entails with family and now having small children, they are mostly my why, like wanting to create a better community, better world. But yeah, I think just impacting health inequities and increasing health equity is what I'm passionate about.
Sorry for walking late. Kelly Hinge, Strategic Initiatives Director. She, her pronouns. Well, for 25 years working in health and development and overseas, I figured, what's it like to work in the States in a super privileged county? So I think Boulder would be great. But what I'm finding is in that space is that there, as Heather, what they were saying is there's lots of inequities out in that space. So I think that jumping into the space has been really good for myself and my family and things like that. And we certainly miss our time overseas and some of the things that it did for us and the diversity and that kind of thing like that. But it's a part of my career I feel like I'm wrapping around, if that makes sense. Maybe it doesn't, but and I do, not just saying because she's here, I do appreciate Lexi and her work in that space also in the past. To have somebody to connect with in some of those spaces has been super helpful for me because I can get in the space where I'm saying, I want to hear your complaints, but real complaints and things like that. So not your first world problems. Not your first world problems. I want to hear what there's real issues out there. And there are those here. So anyway, I hope that's what kind of share a bit. Joe, it's up to you.
Thanks. Joe Malinowski, I serve as the Environmental Health Division Manager, he, him, his. I think my why has probably changed a few times over the last 25 years working here. I think currently it's probably just working with my team. I have a great team that's really independent work, just really professional. Couldn't ask for anything more. And just seeing them succeed, being able to support them best I can is really jives me these days. And also having opportunities to do some cool new things like the work we talked about yesterday at Valmont, to me is really exciting and keeps me always interested. I've always been really interested in having better health through a healthy environment. So it's kind of been my focus.
I'm Desiree Casarozian. I use she, her pronouns. I am finance manager and interim director of admin and finance. My why is growing up, my parents struggled with substance abuse and mental health issues, which led us to Boulder County, Colorado from New Jersey. And I want to give back to the work that benefited me.
That's lovely.
Lexi Nolan, executive director. I use she, her pronouns, and I have this unshakable fantasy of living in a just world, and it happens to, in my case, apply through public health work. And I've had a variety of different kinds of jobs, from global intergovernmental to university-based to philanthropy to running an NGO. And I am now in the phase of my life where I am seeing what you can do in local public health to drive towards that goal. And it is, at its best, it is a lot of fun. It's really fun, and I can't think of anything better to do with my life.
Hi, my name is Kevin Ma. I use they, them pronouns, Health and Racial Equity Manager. And I'm just here to do some long overdue change. Yeah, that's my wife.
And we've got some folks online.
Indira, you can go.
Hi, everyone. I'm sorry I'm not on camera. I have a broken kneecap, so I'm recovering. Um, I love this question about what's my why, because I feel like Joe a little bit. My why has evolved over time. I think I started out really focused on the injustices and all the disparities that didn't change over time, and that we needed to make a lot of systems changes. And I think now I'm at a place where I'm just so grateful to work with such an incredible group of people who are all very much about making those changes as well, those larger systems changes, and are dedicated their lives to it. And I'm really in a place of wanting to support the next generation to be successful, because I think they're going to be facing a lot of challenges in the years ahead. So, just coming from a place of gratitude right now, and thinking about my kids and thinking about how public health has made such incredible societal impacts, and where I think it'll be going in the future.
Thanks, Indira. Daphne?
You're muted.
Oh,
I can't hear you, Daphne.
I'll help you out.
Oh, is that? I want to hear.
Okay. No. Daphne, you're so muted. We can see you, but we can't hear you.
What's the little person next to her on her?
I think she's on her cell phone.
I'll be able to hear you. Yes, I can't unmute her. She's already unmuted on our end.
It's okay. It's not a requirement.
It's okay. It's okay. All right. We'll connect with Daphne. Great, thank you for that. So we will go ahead and move and stay ahead of schedule. Move into the equity discussion with Evelyn.
Well, thank you, everyone. Yes, perfect. So this is kind of part two. So our continuation of our discussion last time to really involve the Board of Health and keep you all updated on our health and racial equity and community engagement work. Next slide, please. So kind of the purpose, again, to continue our discussion on how y'all would like to increase your understanding and involvement in advancing our racial equity and community engagement goals within the county. Next slide. So to continue where we left off last time, you had some specific asks for us, which I greatly appreciate, to kind of see what would help drive you forward or to understand our work a little bit deeper. So what we heard from you last time was that you would really appreciate some more evidence-based context and strategy. I know myself as research background, I really do like evidence-based approaches. Some examples of our explicit program work and some narrative examples. So what's some proof and some local examples that we're working on. Our theory of change and how it changes the work we do. And then lastly, some evidence-based incorporations of KPIs and measurements into our strategic plan. So basically that's just to say, how are we incorporating these values and evidence-based strategies into our strategic plan? Next slide. So just a brief overview, we're going to kind of go over racial equity and community engagement. What does the context and the evidence tell us? How do we take that evidence and turn it into action? And how does that inform our theory of change and ultimately our strategic plan? And then ultimately some reflections from y'all of how y'all would like to continue to stay involved, what worked for you, what didn't work for you, just so we can continue the conversation. Next slide. So we'll start with some context and evidence. Next slide, please. So I won't go through all of these, and of course, we'll send you the slides so you can review these because we have some fun visuals and data and stuff. So according to the Public Health Association, American Public Health Association, and Public Health Leadership Society, these are some of the key principles of public health. Of course, there can be more. We kind of bolded a few that maybe our conversation will touch on today or prioritize, such as addressing the fundamental causes of health risk, advocating for and empowering community, and also having basic resources available to everyone in our community, incorporating diversity, and then also really investing in collaboration. And we can take or if you have any questions about these. Okay, awesome. Next slide, please. So we don't have to read all of this, but essentially, the Prevention Institute is a really great partner that we work with. They have some excellent strategies, data collection, and definitions on some of the key concepts relevant to public health. These are just some of their definitions of health equity and racial justice. But I think what's important to point out is when you read these descriptions, that they're not only just descriptive definitions, but a lot of these definitions involve some form of strategic action. That it's not just, hey, this is what equity means, but this is what it takes to really improve and address inequities. But yeah, take some time to read through them. If you're ready, I can go to the next slide. Awesome. Okay, next slide, please. So here are some examples of why equity is really intrinsic to the public health mission. Of course, these are just a few examples. I'll just read the bold part. So data really tells us the technical arguments. Human rights grounds us in the moral argument. Inclusion itself can reduce health inequities on multiple fronts, and systems are perfectly designed to produce their results. All of these require culture and system change. So all of these are evidence-based examples of incorporating equity and community engagement in public health. And we can take some time to read these too. Awesome. Okay, next slide, please. And we can come back to any slides if you'd like to discuss or if they'll be relevant. I'm sure you all know, I like this cute little graphic, kind of talking about the difference between maybe clinical health and public health. So public health kind of prioritizes populations and systems. So kind of looking at a population statistically or systemically on a large kind of bird's eye view. Whereas clinical health may really want to focus on preventive treatment for an individual or a smaller group of people. So as you can see here, kind of the orange dot looks like it's a little higher in health outcomes compared to the purple dot. So that's kind of individual, but when you kind of take a step back and look at the larger system, you can see that there's a clear disparity between these two groups. So kind of using individual assessment to determine whether or not inequities exist is not really useful in our approach. So that's why we really want to look at a high population level to really understand what are the existing disparities in our community. Next slide, please. I really like this visual. It kind of really ties in how systems of oppression or confusion or misinformation is really impacting a lot of key developmental aspects of someone's life and things that contribute to their well-being, which obviously leads to some health outcomes. Some people call this life course, for those familiar with it. And kind of everything in the blue, I'm sure you can figure out that like public health is involved in almost all of those aspects. So that's why we want to make sure that if we're really trying to address health outcomes, that we continue to work upstream towards the left and really try and address those big structural systemic issues. This is a fun one, maybe for the research folks who like little complicated diagrams. This is essentially the left pillar, the society pillar, and the right side, the individual pillar. It's just showing how there's a cyclical nature between the two. So on the society side, you can see that on a policy context to a social context view or perspective, that there are different levels that affect individual social positions, specific exposure, disease or injury, and then ultimately social consequences of ill health, and how they really inform each other. Where public health is really useful is in these horizontal kind of dash lines. It's essentially identifying areas for intervention and consideration when doing strategy. So if your strategy is only focusing on, let's say, the bottom area, preventing unequal consequences, but you're not addressing vulnerability, decreasing exposures, and influencing social stratification, you're not really going to get the collective outcomes you want. Any questions? I know it can kind of be a lot visually right off the bat. Okay, awesome. Next slide, please. So some examples basically what is the research saying, right? Like we can have all the morals and ethical arguments we want, but ultimately when it comes down to public health and medicine and wellness, there needs to be some data. So some evidence-based strategies that have been done through peer-reviewed research that's very much ongoing and still developing to this day. These are some of the, I guess, more key or priority strategies. So I'll just go through them. Culturally tailored health communication, community-based participatory research, health impact assessments with a focus on racial equity, equity-focused policies and program funding, addressing social determinants of health, engagement and leadership of minority groups in public health planning, and all of these strategies together improve health outcomes for all. Any questions on some of these strategies? We'll kind of go into a little bit more detail. Next slide, please. I like this visual. Thank you, Lexi, for sharing this. It kind of showed a little bit more nuance into kind of those systemic levels of oppression and marginalization and how that can really affect both upstream and downstream factors. And through a lot of this work, you can clearly tell that public health is involved in a lot of these arenas, from the social inequity upstream factors all the way down to trying to work through understanding people's risk behaviors. Where does disease and injury come from? And then ultimately mortality and illness. Lexi, did you want to share anything about this diagram? Awesome. It's a good diagram. Next slide. So what does that say for Boulder County? So of course, every county, every community, even every neighborhood or block has its own data or health statistics. So kind of, obviously there's a lot more than this, but kind of the most common inequity hotspots in Boulder County are chronic conditions. So things like asthma, heart disease, and this especially is impacting marginalized communities, both people of color, people that are unhoused, people that use substances. There's income and economic inequality. So of course that can lead to nutritional deficits, housing inaccess, lack of education. Of course, housing access is a huge one. So you can get people that are displaced, that have to move, that have to commute, that have to live closer to unhealthy environments that maybe aren't as protected as our more privileged cities like Boulder. Nutritional access, of course, healthcare access, mental health and substance use, security and aging. So I think aging population is something we tend to forget a lot, is that even marginalized communities and privileged communities also age, and this can also impact health outcomes over time. And then, of course, environmental health or environmental justice. Next slide. So with some of this evidence that we have and kind of what the research is saying, how are we going to incorporate that into our work, especially our strategic plan? So next slide, please. So we've kind of developed this theory of change. So kind of really trying to summarize what was all the evidence trying to tell us and how can we organize that theoretically and really apply strategic approaches across all of the main areas. So we're not leaving something out or hyper focusing in one specific area. So what we came down to when we did an assessment of the different strategies is that it ultimately comes down to cultural work, systemic work, and community action work. So we gave a little bit of examples of things we're trying to roll out or really integrate into our agency over the course of our strategic plan and beyond. So some examples of culture include competency training, not only for our staff, but for the partners we work with, creating engagement spaces, narrative change, such as our health justice framework, empowering staff stories, and cross collaboration. And then for systems, we have policy advocacy work, impact assessments, evaluation of our programs, data collection and reporting, and identifying sustainable funding sources. And then lastly, we have community actions. So some initiatives are like language access, advisory boards, community compensation, cultural brokerage, and development partnerships. Any questions? Or does this kind of make sense? Awesome. Okay, great. Next slide. So our strategic plan is something that isn't just based on ethics and morals, right? This comes from a lot of evidence, a lot of research and data we've collected from our own communities. So we're really trying to integrate a strong evidence base for why something like racial equity and community engagement is integral to the strategic plan. So a lot of people may say, you know, Boulder County is predominantly white and privileged. Why should racial equity be a component, right? But when we look at racial equity and community engagement work, similar to how we look at consider vaccines, right? Like if you are supporting your most marginalized and neglected communities, experiencing the kind of the worst brunt of health outcomes, that it inevitably benefits the whole system and the whole community. Examples of just so how do we demonstrate accountability to this? So we really want to make sure that we're creating a clear and efficient line for monitoring, evaluating and learning about our strategic approaches. So in our strategic plan, we're really trying to incorporate KPIs that are really specific to equity and community engagement, some of them relating to our theory of change, or all of them relating to our theory of change. Creating internal data infrastructure and processes for eval, such as staff surveys or community surveys, because you know we can say we're doing all the right things, but if the data is proving otherwise, we may need to adapt. And then also budgeting according to the evidence-based needs. So what are the main priority areas we want to focus on, and then how can we invest our funds appropriately? Next slide, please. Oh, this is quick. Okay. Next slide. So we definitely wanted to prioritize some of the most of this time to really have a conversation with you all. So it's not just, you know, a presentation that you're just a one-sided presentation. So we really wanted to talk about your role and how you would like to feel supported. So from our February retreat, we identified some potential roles for the Board of Health to kind of support us or to be involved in. Some of these, and I believe everyone said that they would like an active role in kind of being involved in this work. So some of those being approving strategies, reviewing annual outcomes, connecting to community partners and organizations, providing input on prioritization of our work, representation of public health as an equity-focused organization, even connecting with other Board of Healths doing equity work, and learning how to champion our commitments and values. So these are just some of the things we identified. Of course, we can't do all of them at once. We know you're busy people. So we wanted to kind of pose these questions to you. We don't have to go through and answer all of these questions, but kind of these could be good conversation starters or something for you to reflect on. I guess based on our brief little presentation, did the ideas and visions resonate with you? Was something missing? Is there something else that you would like to have more of, whether it's more of that hardcore research and data and statistics, or more about the strategy and implementation? What does having an active role as a board member mean to you? Of course, you'll have full-time jobs outside of this too. So given the time and the energy and capacity that you have, how would you really like to maximize your involvement with this work? Additional and or refined roles. So are there additional roles that are maybe missing here that you think we need to prioritize a little bit more? And which are most important to you? Maybe is there a top three? Does one come after the other? How do we operationalize these roles? So how can we really build this into our time together? And then ultimately, what would that take to set you up for success? So are there additional resources, learning opportunities, trainings that you would like to be involved in? But yeah, I guess we'll just open it up to y'all. And of course, you know, we can go back to any part of the presentation. I know we kind of breezed through it. So yeah.
I'm happy to jump in and start the conversation. So thank you, Helen, for putting together that presentation and walking us through that theory of change and some of the work that's already being done. I think what would be helpful to me as a board member is to also have staff recommend, here's what we think would strengthen the Board of Health's role in supporting this work. Here's sort of our priorities for you in supporting how this plays out at BCPH. I mean, I think it's, you know, we get a sense of some of the ways that equity is woven into the programming, but I think it would be helpful to hear. Here's some ways that we would recommend the Board of Health could demonstrate your commitment to this work. For instance, I think we talked about, are there training opportunities that would help us align with what staff is also being trained in so that we have a common understanding about how staff is approaching this or the language that's being used. That would be helpful for me to know that way. Well,
I enjoyed going to the meeting of local health leaders. That kind of thing. See what's going on and just sort of knowing where things are at different health centers, and we're all treating the same population. How we can help to more practical.
And Lindy's also,
I attended a training recently. I don't know how, it was through one of the emails, but it was like a leadership training with other local public health department, right, board members. It was so nice just to be in the room with other board members with their counties. And so I would love more opportunities to do that. And so to the point of like hearing how other public health are dealing with this issue, like would be interested in being a connection point for that if there's opportunities for these, I don't know.
I reached out to CDPHE because they have like a whole office that like handles their board. I'll see if they have any.
I mean, even those of us that were in the meeting, right, we can form a subcommittee right now. Like, oh, I got your email. So that was super helpful. I think because I'm not in the day-to-day work within the department, it still feels a little abstract to me. And so when we talk about like the KPIs, can you give us like any examples maybe?
Yeah, so that's a great question. So currently, our strategic plan right now, we haven't fully gotten to the monitoring, evaluation, and learning part. So our KPIs are still dependent on the finalization of our objectives and our activities. But we do have some general ideas about specific goals and what potential success markers could be. But I think as we finalize that with Kelly's team, we're going to move on to that MEL part of like, what is a solid KPI? How are we going to evaluate this? What are we going to do to adapt? Kelly, Lexi, I'm not sure if you want to add more about the strategic process.
I'll just mention in relation to KPIs, it's a priority for the county as a whole. And so that is an opportunity for us to align. And within CALFO, we are also creating an opportunity for different public health departments to share their KPIs in different spaces, just as a mutual kind of support activity and to see where there's alignment, which might also provide opportunities for testing interventions against each other in specific areas. So I think that this work will continue to evolve. And what's really important about KPIs is that it's not just a way to kind of look at how far you got, but ideally it should open a conversation about what's working well in this space and how do you pivot, what's the emergent learning that's happening that has to accompany it. So Kelly, go ahead.
Yeah, I just wanted to add that. Thanks, Lexi. I mean, you hit on one of the points I was going to say is that it's about learning too, right? And we're looking at this space not as we're in competition with somebody or we're, you know, that sort of thing like that, because we're going to be having some KPIs that may be slightly different in different spaces. And also on top of that, we need to be flexible. And in the fact that when we review these spaces and we look at the learning, do we need to change things? What are things that we're going to learn along the path along the way? I mean, we're not, my annoying line is we're not reporting to Congress on this, right? So, I mean, let's see how we can use this work in order to, our goal is to create our impact. And that's what a KPI should be looking at, is helping make sure you're making impact in that space.
In my world, one of the hardest things with like addressing equity issues is just having really good data on what's happening in your world and what a poor job we do about collecting that data on multiple fronts. And so I didn't know if you guys have any like hands on what that looks like. I've done a lot of QI work in the hospital setting about how we're collecting race, ethnicity, payer, gender identity, what a really awful job generally we're doing about that. And so I didn't know if like any of this work touches how we're even evaluating inequities with the limited data that we often have.
I'm so grateful you asked that question. I could talk for hours, probably years about this. Data justice is super important. And I think all our programs do really great work, but of course, because of grant reporting procedures, they expect like what you said is like categories like gender, race, sexuality are very much based on the grantor's kind of perspective. So even coming up with a model, which I've been discussing with some of our programs, is how do we collect our data accountably, but then translate it for the purpose of grantors, or even kind of informing them, hey, maybe there's a better way to collect this. For example, a clear example that I like to use a lot is we have huge health disparities with our Latino or Latina population here. But for those that know, obviously, like Latina is not a race, it's an ethnicity. And even meeting with a lot of local community members who look like me, darker than me, right? And I asked them, hey, well, obviously this is an issue when you like, do the census or you go and input your medical data. What do you normally put? And they say, oh, I put white or Latino, or I don't know what to put. I put
Or some other race.
that's even an option, right? Then that can really skew your data because if you're also incorporating white Latinos who do exist and tend to be more well-off positions, that it can kind of skew the data to show that maybe the health isn't as bad, but then you go into the community and you're like, whoa, there's a lot of disparities. So even sexuality, gender, right? We confuse gender and sex all the time, right? Male versus man, female versus woman. These are two very different things. So making sure that when we do our program evaluation, that we're also creating like what you said, which I really enjoyed, is what's our common language? And even if our different programs are collecting very different data and reporting it very differently, it doesn't really lean into that purpose of alignment, right? So how do we create also a data justice perspective on this, which I think will come out of the end. Thank you for that.
Can I add to that too really quick? I think one of the important things we're doing in this space, we want to do in this space, has to do with some of the work that of our priority around community engagement. Because I think one of the things you're saying, Amber, is that a lot of times we have these sort of superficial data spaces, right? Or we collect data from just gatekeepers per se. And there is a lot of the disparities and a lot of the drives, unhealthy behavior or whatever is a couple levels down on the onion, right? And it's getting to that space, which is a difficult, right? It's going down to go path right after the road stops. That sort of space, right, is something I think we want to work toward. And that's that combination of the health justice work with community engagement and how those spaces work. And I think that's really exciting, defining that, but then how do we go lower in those spaces, what's really driving the space.
Thank you for that.
Joe? I think it's a good practical example of that. And I think where the board can help, I don't think these board approvals, but it definitely would help to have board support, is we want to be able to reimburse community. You can call it honorarium. And there's not really a policy around that. Currently, it's loosely, I know we've done it when we try to get feedback around immunization. We have a small committee group that gets together. We'll give them a Visa card with a certain amount of money on it for coming, because we're getting information from them. And that seems very clear to me that it's equitable and makes sense. But we also want to do it in these bigger settings, like the Valmont. And we obviously can't give everybody one. And we know there's certain people there that represent their particular communities that we would like to reimburse, but we're worried about the perception of giving certain people money and not others. So I think we really needed to come up with a policy that's very clear, and the county doesn't have one either. That I think would be very helpful to get to that lowering of the information from the community that maybe we normally don't hear from.
And I appreciate you pointing to, here's a specific policy that we think would increase equity. That is what the board's role is, right? And the board is, we want to support a program and we want to support the day-to-day operations, but our role is really to focus on what policy is supporting the needs of the organization. And so if there's a policy that the board could consider, that staff brings forward, that, would help increase equity, that's a really good hit for us. You know, I mean, so I think those are the things that we're looking for too, is, we might have some ideas. I'm also very conscious of the fact that we are a very narrow demographic on the board. And so it's helpful as we consider policy if staff either has input from communities that are not represented on this board, or if there are ways that staff thinks that this board could get better input from communities before we consider policy, that feels very relevant also. So those are the spaces that I think really are important for our board to be in on, is policy. How do we make sure that we're hearing from community when we consider policy? And then how do we support the strategic priority around health equity? And is it, I actually need to check myself, because if somebody from off the street asked me, how does public health think about equity or health equity? I would say we, have a strategic priority around health equity centering race. Is that actually accurate?
Right.
Is that accurate? That we center race?
Yeah.
Okay.
And
That's accurate.
Okay.
yes.
But I mean, I think this is the question, right? And this has come up from other people, is how would you talk about how public health thinks about health equity? Is it accurate to say we're centering race? And then when someone says, tell me why you're centering race, I feel like the board needs to have a better understanding of how to answer that in a way that aligns with the way that BCPH is thinking about it.
Yeah, I really
Explain that.
Yeah, no, I really appreciate that, because even in my work and like my background, even when I went to school for race equity and human rights and stuff, everyone has such a different perspective of what it means. And I think to Kelly's point too, is we really want to lean into that intersectional component, because of course there may be a time, and this probably happens really frequently, where we work with a community that isn't of a racially marginalized identity, right? They could be all white, they could be all college educated, they just live in a specific area, right? And I think when we talk about race, we're not talking about race as the census labels, but the process of race. So racialization, which is the process of othering someone. So whether it's substance use, LGBTQ, how are these groups racialized? And then of course, race as the more categorical topic, such as, what you look like, how you're perceived. That's also really important data we want. And I think back to that data justice perspective is I would like for us to be able to get to a place where we do have raw data, and we can actually do some intersectional analysis with a lot of the research that's coming out, where you can say, okay, controlling for age, what communities are most impacted? Controlling for race, what communities are most impacted? Controlling for race and gender, what communities are impacted? We have to be able to have analytical power as well, being able to do linear regression, having data scientists reporting out that data, because you can't tell if you're fixing a disparity, one, if your data collection is skewed or antiquated, and then two, if your programs are actually having any impact, right? So thank you for. And yeah, I think to your point, I think it's maybe a good opportunity to practice language and almost kind of how we do media spokespersons training, right? If someone were to ask you, hey, what do you mean by this, that you'd have some talking points to say.
Yeah, that would be really helpful.
Awesome. And I really appreciate your comment about wanting to be more involved in policy and clear, hardcore examples. So I think that's awesome. And I think we have a lot of avenues where I believe Heather's division, I believe most of our divisions have some kind of community, what do we call them? It just left my mind. Community boards, community groups, advisory committees.
Cultural
Coalitions.
Cultural brokers, yeah, we have cultural
Yeah,
brokers.
which one?
We have advisory groups of LGBTQ youth, of,
Oh, affinity groups?
or
Coalitions, affinity groups.
yeah, people that advise our work and give us feedback, like Family Connect.
The difference.
Yeah, Family Connect. Yeah, so maybe it's about creating channels, groups, or creating kind of that, your approach of, what is the community saying that we're not seeing or experiencing that we can incorporate.
Yeah, I think if we're going to consider a policy that's going to impact community, it would be helpful to, if those groups are already existing within BCPH's networks, to ask those groups, like, tell us what you think about this policy that the board's going to consider. Do you think this is going to impact you or your friends or your neighbors? Because again, like I feel like we are pretty limited in our lived experience on the board. I don't mean to say that, but I just demographically, again, we're a pretty narrow group of white women. So I think it would be helpful to have some of that.
I think that's part of what an infrastructure for the community engagement work is going to do for us, is allow us to be able to kind of collect information like that and to have an organized approach that's consistent and to really be inclusive and such. But I cannot let you walk away from the table without having a 30-second elevator pitch on why do we center on racial equity.
Please, yeah.
We have 2 minutes left this conversation. 30 seconds first.
Race is such a dominant force in explaining social stratification, economic stratification, political power stratification in the United States, that you can't ignore it as the central feature of why our country looks the way it does and has the challenges that it does. So in one sense, it is inherently a critical issue to look at. And the process of looking, especially in public health, through a racial lens, teaches critical thinking about how to apply those same lenses to other topics of historically excluded or marginalized populations, whether it's LGBTQ or religious minorities or whatever. And what they all have in common is a lack of political power and a lack of and exclusionary tendencies for a variety of reasons that function in systems to create patterns of inequalities and often function in social contexts and culture contexts. And so those two components of systems and context for marginalization and exclusion create a framework for how do we begin to tackle inequities centering on race and recognizing how we apply that approach to flexibly to different kinds of issues.
I appreciate that, and maybe we can dial that down like.
A lot of years of
That was good. That was good. But it's, so my point is that it would be helpful to have a couple of some talking points, because I do think it does come up, people ask. So and I support BCPH's approach to it, and so I want to be able to communicate that support.
Thank you for that. And yeah, maybe it's like a one pager, the quick points. And I think too, for our strategic plan, Kelly and her team are kind of making space to introduce the strategic plan with kind of a 2-pager focus as to why things like racial equity and community engagement are important. So maybe while we were writing that, we can keep the Board of Health in mind of like, they can use this 2-pager to be like, here's why we're doing it and here's how we're doing it.
We should also eventually put stuff on our website.
Yeah.
But that is videos, not written. Like, so like, whoever, and frankly, it's not Lexi or me or Heather or somebody like that talking necessarily. Maybe it's a community member or partner or Kevin maybe as a leader in this space talking about that. And the same thing about community engagement, right? How do we approach that? Those sort of like 1 minute, 2 minute videos also, I think, are really pretty helpful. So
Graphics and visuals, sometimes that's all you need, right? Sort of like robust academic jargon. It's like, just give me some pictures of how things connect. So yeah, we'll be trying to make all that for y'all.
The last thing I'll ask, and I think it relates to us saying like, we want to know what other boards are doing in this space. Like, I really appreciate the emails that Melanie sends out about like what's happening in public health in our realm. And I would say this seat would be super helpful. You guys are on so many like committees and boards. We saw that list recently about like how many spaces like the department touches. And so if you guys are hearing about other departments and other spaces where stuff is happening, I'd love to know about it. Because I think that sometimes our scope of what this work could be is probably more narrow than it should be. And so as we're seeing how other people are using this space, I think that would be helpful.
I think that's such a great point, and I think there's a lot of avenues where we can connect you. I guess a question back is, would you prefer it stay like local to kind of metro area, Colorado, or even national? Because, you know, it might be the case that we may be the only ones in Colorado that's a little bit ahead, but maybe more well-funded or higher capacity states like California and New York may have boards of health to connect with or are part of some kind of association to connect with. So yeah, I guess.
Yeah, let's dream big. Right?
Yeah.
If it's big enough to catch your attention, right? That you're thinking that's a cool idea or cool program. I'd love to hear about it.
Awesome. Okay, great.
Just wait a minute, it gets to be too.
It's gonna be okay.
That's okay. I think like that myself. It didn't work.
Jordan, are we good on?
Yeah, we need to move on to the next topic.
Oh, thank you, Helen.
Of course, if you have any questions, you can continue to answer them, and then look forward to part 3 at the next retreat.
Great. The next item is board business. So it's where we will hear your thoughts and opinions on all sorts of board related items. So the first off, Patrick will talk about some Board of Health emails and the CDPHE annual training. Landry, I will send you a recap.
Okay,
of all
thank you.
this.
And I'll do that training.
Okay.
Well, we have a plan.
We have a plan. Yeah, we'll keep you up to date. And then I'll talk about, we need a representative for an audit conversation. So Desiree, if you have anything else to add to the conversation when we get to that. The priorities for myself, Patrick, for the third quarter, and just some reminders of our meetings through the summer. So take it away, Patrick.
All right, so sent an email to everyone, but just to kind of recap, it's an email about an email. So we looked into, we had a question, right? I mean, sort of why did this come up? And it came up because some of the board members expressed some frustration and difficulty accessing the calendars, right? Because it's a separate calendar. It's not synced up to your work calendars or your personal calendars. So we talked with IT and we tried several different things. And because of basically the firewall that's around Boulder County, especially because it's a government website, some of the functionality that would normally work within a calendar doesn't work. You can't share a calendar link externally. So we came up with the best solution is to give you a bouldercounty.gov email if that's something you want to do. Would it, and legal and HR said it's fine because we do the same thing for volunteers. So, I mean, you're a volunteer board, so we would treat you just like another volunteer. You get your own email. The advantages are, right, you'd have access to the calendar. You can sync it up to your, if you have a Google Calendar. The downside is it will not show you the details. It only shows in your Google Calendar as a time block. And that's a restriction within the county. I talked to county IT about changing that, and that's not something that they're able to change today, but you would at least see it on your calendar as a time block. And then you can access the calendar directly, either through installing the Outlook app on your phone or through just outlook.com. And then you could, you'd get updated calendar invites. So that's kind of that's some of the positives to it. I kind of indicated there in red what the drawbacks are. It's sort of not a perfect system of doing this, but it is a way around it. It works. And then the other thing we can do is we can then give you access to some internal files that we can't give you today. Jordan and I played around with how do we do that? And again, because the firewalls with the county, every time you try to share it outside of .gov, it just breaks. So this way you'd have better access to the SharePoint site, the Teams site. Within Teams, there are things you could see. I could do a quick demo, but you'd be able to see, for example, we put together an agency calendar of what's happening across the whole agency by program. And you'd be able to easily have visibility into that because that resides internally. There's some other documents we can give you access to.
And like, there's a way for Patrick and I to also have access to the inbox, so you won't have to monitor it, because you'd probably be on our health all emails, so that's just more emails you're getting, but we would also be the back end. That this just gives you more access.
Can we keep our communication also going to, for instance, our Gmail accounts?
Yes,
Right,
of
okay,
course.
so we could.
Like emails, but then like you use the .gov to access the calendar, to access the see.
And right now, some of the workaround with this, like, for instance, the files that you share, I have to put in my email and then they send me a code and then I'm able, so.
Yep.
That would get rid of that step. I have a couple of like nervous things.
Yes.
Yeah, no, share.
I mean, for one, because, you know, everything flows through my Gmail now, so it's just one more thing to monitor, which.
And you, unfortunately, you can't add it. I tried.
Yeah.
You can't add it to your Gmail
Sure,
profile.
I hear you saying that, so that's why I'm like, can we still get things through my Gmail, because I'm looking
Yes.
at that all the time. I also, I mean, this has come up a couple of times from the county attorneys, is that our Gmail, our personal emails as volunteers cannot be.
Right. It's core.
Right, that's right, Corad, and so this would, I assume, be portable
Yes.
communication, anything that goes through at the .gov, so that's, I think, just really important for the board to understand.
It's if you use the app, it makes it sign out of your other accounts. Is that true if I was using it on my computer as well? Like, can I be signed into my Denver Health Outlook and?
If you use Outlook as an app, so if you have the desktop app for Outlook, you can be signed into Denver Health for that. If you tried to then add the Boulder County email into that app, the desktop app, you wouldn't let you do it. It's what you can do is you can access the Boulder County email just through a browser window through outlook.com, and then keep your professional email through the app. Or you can have two, actually, I don't think it'll let you open two tabs. You have to open two browsers. Because you have to I played around with that. You can't have Outlook open in two tabs with different Outlook accounts. Yeah.
The way that you were sending calendar invites right now.
Yes.
Are you using a workaround? Because those do show up on my Gmail.
Yes, so
right?
that,
Yours do, but Lexi's don't, right? I get it from you, but I don't get Lexi.
so there was an instance where I had to connect with county IT to update their firewall. There was something, a Gmail thing was misspelled. And so they were able to update that. I wonder if it's like person specific, like you get all my stuff now. I don't know what's wrong with Lexi's. So right now it's like I put it on the team calendar. So if you do go to the SharePoint page, it shows up, but then I still have to add you individually. And so if we were to do the .gov, it would just be the team, and then it will pop up on your Outlook calendar, not your Gmail calendar. So, but then you can then go in and copy that to your Gmail calendar. So it's still work around.
Yeah.
There's Band-Aids to all of this. So-
I hate, because I hear it creates an extra step for you, which I don't want to do. I'm also concerned that if it is not in my Gmail
Right, you
calendar,
have to-
it's up to me to sync that.
It's gonna be a lot.
I'm gonna miss some meetings.
Okay.
Yeah,
You can send it to both, but.
Yeah.
Sorry.
I will second that, Morgan.
Okay.
My whole life is through Google. I have like I have 5 Google calendars. If it doesn't come to me through my Gmail address, I will not see it. But I am willing to go over and to log in to look at things that are important that I need to. I just need to be alerted through my Gmail.
I will get this account if it only means I can access like the calendar. Like, I want to be able to see the department calendar. And so if this is the best avenue to do that.
We can consider, I mean, and maybe we have to do a hybrid approach, right? Where it's all the calendar invites are still your Gmails. And you just have a login so you can get to internal files and restrict it. Kevin's got a suggestion.
I'm not sure what the IT conversation is, but I know Power Automate's the thing where you can
Yeah.
Is Power Automated an option so that you can send the same email to both Gmail and Outlook automatically? I don't know if we have that capability, but it could be.
I mean, I think we could just easily add the emails to the calendar invite, so I think that's not necessary. Yeah.
Amber, would you be willing to be a tester? Okay. That's what I heard, because I think yours would be great, because like you can see the Gmail, your multiple Microsoft accounts. So I think that could be a good testing way. And then we will report back to the other Board of Health members.
Amber seems more organized
Yeah.
than me. I'm not sure her experience will be translatable.
If I stop coming to meetings.
Okay. When Amber misses a meeting, it's because she wasn't in the email calendar.
Okay.
And yeah, I mean, we're not invested in one way or the other.
We appreciate all the work that went into exploring,
I think a lot of this too is like, it looks a certain way from our perspective, we're like, yeah, this will totally work, and then it does.
yeah.
So, okay.
I feel like my mom right now. I cannot. I'm not your account. Please just make it all come into my current account.
The county is not very Google friendly.
Yeah, no, I know.
And normally you can easily share an Outlook calendar with a Gmail calendar. It's just that button just literally does not work within the .gov domain. Yeah.
All right. We'll
Moving
connect
on.
with you. Thank you for that.
Did you get the note about Lexi's calendar invites not working?
Yeah.
I was trying to do it, couldn't quite get it. Required trip, skip that slide. So some of you have taken the training before, right? So I don't want to sort of assume that, but we took a look at what's out there now. And if you haven't done it yet, there's essentially 4 topics that you have to cover. And it would take each person about 2.5 to 3 hours to do the training. And I'm going to kind of skip down here. One of the ways that we could do it more efficiently is you can divide the topics up. So everybody has to do the yearly training introduction, 30 to 45 minutes. You have to choose one course from public health governance, and there happen to be 3 of those. And then you have to choose one course from emergency management, and there are 2 of those. So you've got 5 individual courses that you have to take, and we have 5 commissioners. So each one of you can just pick one of the individualized courses to do, and then you have to do the feedback. Everybody has to do the feedback individually. So really then you're only looking at each one of you only having to take 3 courses. And you can pick which course sort of fits best with what your interests are. And then I thought at the next retreat, just do an informal share out. Hey, here's what I learned in the emergency management case study course about the Marshall Fire, and just share that back out. To try to make it efficient for everyone. It's either that, or we could just all get together as a group and just kind of go through it for 3 hours. That sounds fun. I've done these trainings.
It's going now.
Yeah. So that's the recommendation of how we can do it. They're all on the Cotran website, and it looked like we got an email that Brooke and Landry didn't have current registrations, or was under a different. Could be under a different one. Yeah. And they acknowledge in the email that the account could be under a previous email. So, yeah.
I know. They have not removed me from my post, but I am delinquent in finishing my.
And there's a couple other new ones out there. Policy development was a new training that they offer this year, and an emergency management case study in Marshall.
Morgan, do you want to just assign us and send out the link again?
Sure. Yeah. If you send me the link, and then if if one of these really jumps out to you, please let me know, and I'll be sure that's your assignment.
And is this calendar year or our appointment year?
So it has to be completed every year by December 31st. That's annual training. So you can technically take it on the 31st, and you can take it on the 1st. You can set an duration. So it's the decision that Morgan, we will give you this list, and you
I will assign, and thank you for helping us go through these efficiently.
Yes. I want to be every board member has taken the annual training. I wanna be-
Okay, so I don't want to let you down, Jordan.
Thank you.
Down for another year.
Okay. And we have more information in the slides as well, so I'm gonna give more information, so. Yes,
Are we at break? No, not.
no, I had a few slides. So it should be the audit. All right. Desiree reached out to me this week, Clifton Larson Allen, who is our third-party auditing contract. They request a Board of Health representative to discuss routine audit inquiries. Last year, that was Board Member Harrison. So we wanted to decide right now who would like to be the representative for this year. And Desiree, do you have more information of like what the questions or conversations are?
No, I think actually I'm not supposed to know what's in the conversations. So that happens amongst our own staff too. They're going to reach out to some of my finance staff as well, and they will just ask about, you know, the ethical practices and other questions that would give you more of an indicator of how we're doing morally in our financial systems.
Yeah, I can say
Brooke,
last year they really just asked about our processes and if I felt that I had been given adequate time and information and how I requested additional information as needed, that kind of thing. It's very process focused.
I can say from having been on the receiving end as an employee, sometimes they'll say, do you think anything unethical has happened that you witnessed? That might not necessarily be a board question, but those are the types of things that they might inquire about.
How much context do you feel like you needed, Brooke? Like for those of us who are new.
I would say I would say probably somebody who's been through at least a couple rounds of budgeting. So probably, you know, Morgan, Lindy or Landry.
I'm happy to take this one on if no one else is jumping to it.
Thanks, Lindy, for filling the awkward silence. Thank you.
It's usually pretty quick. It's like 15 minutes.
Yeah. This doesn't sound like a massive commitment. Yeah, I'll definitely help.
Thanks, Lindy.
Thank you.
You're
I
welcome.
think it took me 10 minutes. I think it was 10 minutes.
Perfect. Love it.
Next one. So these are just the priorities that we'll be focusing on for the next quarter is to complete the bylaw review and revision. There have been elements that haven't been formally integrated into bylaws from our our first quarter retreat, excuse me. The changing of sitting public comments at 4 o'clock, cutting those off. We moved back to the Baltic room, so I don't have to change logistics that much because it referenced the Baltic. So I'll continue these conversations with the county attorneys. I've been working with Kate and Carrie Doyle. So as those come through, that'll be for the next retreat. Then finalize integration and access to Microsoft products. So this is based off the Board of Health email. So Amber, after we test, we can start finalizing documentation for those. Completing a program spotlight survey. So the program spotlight, I believe we started around this time last year of having more strategic conversations of the programs that we have here. But sending you out a survey to complete of like, we feel like this is a really big priority. Instead of us just rotating and trying to determine it on our own, but having that Board of Health perspective as well. Having a formal check-in with Amber, so your first year is ending. And then Morgan, if you're happy to join that, and Lexi, just to make sure you have everything you need. How can we help support in going into your second year? Preparing for the annual Board of Health member reappointment or appointment, depending on Landry's decision. I just got the email for that today. That process has started, and technically, if Landry were to not decide to be reappointed, we would have through July 10th to go through the application process. So all that is in the works, and I can work with Landry and Morgan on that. Oh, Landry, you have something to say?
I'm gonna reappoint. I talked to Morgan about
Perfect. Cool. So I will connect with you. I'll connect with you on that decision. Planning for the third quarter retreat. And then the last one, just any other thoughts or feedback. So SharePoint, how's that working out? Are communications working? Do you want more emails? Do you want less emails from us? Are you getting what you need? How have the board packets been? Just general Board of Health thoughts. And I know we put a pin in this from awaiting land use decision, expansion of the board. Do we want to see? Yeah, I kind of figured
It's
it's
still something I would love.
okay.
I don't know what, so I guess, I don't know what needs to go into that. Do we have a board discussion where we gauge how the rest of the board feels about board expansion and then we look at our bylaws?
Okay.
That seems to be, to me, the sort of obvious steps, but
Morgan, is
maybe.
that something the Board of Commissioners directs though? I'm a little confused by that.
Yes. So they would technically be the like appointing body.
They'd appoint, but it's our bylaws. So we would make the decision if to whether or not we wanted to expand, I believe. The number, right? That's up to us to amend our bylaws to expand, and then the commissioners are the ones that appoint any new board members that we would add.
Would we want to first have a conversation with the Board of Commissioners just to make sure before we start walking down that path that we're aligned on the reasons and policies around it?
Yeah, are they
Yeah.
asking us to expand? Is that?
No, it's something I want to do. Or I want to explore with the board. So I think, Lindy, yes, I wouldn't want to just throw that at the commissioners without any heads up, but I do think as a board, we haven't had that discussion. I sort of gave my real quick pitch, I think, at the last retreat as to why, but you know, if we're gonna amend our bylaws or thinking about amending our bylaws, then we need to have a board discussion about it.
Yeah, I can check with the county attorneys to get any other logistical. I have contacts from CDKG who have other boards, like expanded boards. But yeah, so I think there needs to be some internal conversations before we,
Yeah.
yeah.
So I don't know,
what.
when we would, when's the right time to have that, the next retreat or?
Okay.
Is that, I'm thinking also about, you know, if appointments happen on an annual basis for the county and those don't open until June or July and they're not appointed until August or.
Well, there's a summer appointment and there's also, I believe, a winter or fall, like a later in the year.
Okay.
It's early,
Okay.
so we can make it happen. There's. Any other thoughts on anything else board related? What about
No, I
that?
would just say, Jordan, thank you to you and Patrick for such awesome coordination and facilitation. It's been great.
Thank you.
Thank you.
Anything else on the management team? Like, how's it going with? We have 3 minutes, or 2 minutes.
This is the third, by second quarter, I mean through. Yeah, April, May, June.
Yeah,
Oh, through September. I mentioned that.
Yeah.
That's what it is.
yeah.
I know the remind.
Yeah.
The strategic plus.
The strategic plan.
Yeah, September.
All right. I'm also always open for feedback. It's just anything. So
Thank you for all the code
thank you.
work and keeping us
Yes.
running.
And just reminders for upcoming meetings. June 10th is our next Board of Health meeting. You're having the executive session from 4 to 5:15, which is right before the meeting. We'll be here in the Baltic. Also, you can join virtually. It will be closed to the public. And Lexi will be attending that one. And then we jump right into our regular meeting at 5:30. There's nothing in July, so I hope you have a good break. And then we tentatively have the August budget study session scheduled for the 21st from 4:30 to 6:30 p.m. So we will let you know if that changes based on conversations. And with that, we have a 10-minute break. So grab some food. We may rearrange the room a little bit. So thank you for that. And we'll move into the next section. Those are virtual. I'm going to mute the room and we'll come back at 3:30.
Thank you.
Please say your name, pronouns, and your title.
Hi, I'm Jana Peterson. I identify as a white woman. I use she, her pronouns, and I am the Boulder County Administrator.
Lexi Nolan, I'm the Executive Director of Boulder County Public Health. I use she, her pronouns.
I'm Desiree Kazarosian. I'm Finance Manager and Interim Finance Director, and I use the she, her pronouns.
Good afternoon. My name is Joe Malinowski. I serve as the Environmental Health Division Manager at Boulder County Public Health. He, him, his.
Hi, everyone. Kelly Hench, she, her pronouns, and I am the Strategic Initiatives Director, Public Health.
Hi, everyone. Heather Crate, they, them, theirs, and I am the Community Health Division Manager.
Patrick Cannell, he, him, and Administrative Assistant in Boulder County Public Health.
Jordan Thomas, Business Operations Manager and our Board of Health Liaison. I use she, her pronouns.
Hi, everyone. Ramona Barano, CFO for Boulder County, and I'm she, hers.
I want to start this everybody. I'm Dr. Lunchman, Brown Latina, she, her, Asia, and I'm one of the county commissioners.
Good afternoon. I'm Claire Livio, Commissioner. I identify as a white woman and use she, her pronouns.
Hi, everyone. Ashley Stolzman, one of the county commissioners. I identify as a white woman and I use she, her pronouns. Hey, everyone. Kate Haywood, Assistant County Attorney. I identify as a white woman and I use she, her pronouns. Hey, everybody. Amber Johnson. I identify as white woman. I use she, her pronouns. I'm the board members.
Morgan McMillan, she, her. So I identify as a white woman. I am the president of the Board of Health.
Everyone, Marianne Scheichel, she, her, AM pronouns. I'm a justice program coordinator for Boulder County Public Health.
Natalie Springett, white female, she, her pronouns. I'm the commissioner's deputy.
And we do have, although I know we're not going to do all the online, but we do have our other 3 board members who are also online too.
Lindy, do you want to introduce yourself first?
Sure. Hi, everyone. Sorry I couldn't be there in person. Lindy Hinman. I identify as a white woman. I'm a board member. I also use she, her pronouns.
Landry?
Yep.
What about Brooke?
Brooke Harrison, board member. Sorry, I have to be quiet. Her husband's on a meeting.
Thank you so much.
I'm happy to, I'll just say welcome everyone and thank you to the commissioners for being here and joining us again for this conversation. And thanks for the staff who has worked quite a bit since the last time we all could. So looking forward to the conversation and I'll turn it over to Lexi.
Thanks so much, Morgan. I would like to start by thanking the Board of County Commissioners and the Board of Health, as well as our staff for their patience as we worked through closing the 2023 books. I also want to give a special thank you to OFM and especially Ramona, Emily, Julie, and Mitch for their guidance to help us align with county processes and make sure that we were meeting commissioners' expectations about presenting information. And finally, many thanks to Desiree Kazarosian and her staff for the very long hours that they put into ensuring the presentation was able to meet the expectations of today's meetings particularly for demonstrating transparency and stewardship. Desiree and I will be reviewing the slides that we previously sent to you all last week with an update that reflects our final changes to Oracle that we will highlight when we get to them.
I think we're ready for the next.
Yeah, we are.
So here's where our Oracle closeout ended for PH 13. So when we got direction from the board that they wanted to also see not just personnel, but operating expenses being reflected in PH 13. We did our very best to go through and comb through all of those entries and to reallocate entries that were made to PH 11 to the PH 13. Unfortunately, we didn't have enough time to go through that entire year of data to make those corrections. So we did eliminate some of the smaller amounts. And there was a point that we just had to close out that process in order to meet the audit deadlines. So you'll see reflected here You see us slightly overspent in the personnel. The OFS is the transfers from the county, the revenue, obviously. That's an error that 2915, we worked to clear it out, but it wasn't worth the effort to work within the system to get that to zero for you all. And then operating expenses, we ended up at 45.69. We could have spent more time with that and gotten that closer to that zero amount, but we didn't have time because of other obligations that we had to meet. Any questions on that?
Okay, and I just want to confirm a question that Commissioner Levy had last week about the invoices that we weren't able to transfer. We just absorbed those through our reserves.
So this would have been coded to PH 11. So we weren't separating PH 11 and 13 for operating expenses.
Well, first of all, I just want to say thank you for inviting us to your Board of Health meeting. It's been a while since we've all been in this room together. We've met frequently since that meeting, just as commissioners and one-on-ones with board members who requested time. And certainly with often staff on different projects and things like that since that. And just want to appreciate all of the work that went in to be able to get us back to what we'd heard and asked to meet in February, and for scheduling and for extra data and article and all the pieces. We'll hear now in May to hear from you. So I just wanted to start the conversation because for me, it wasn't just about the budget amendment, and you may be going this way, and it might just be the way that the presentation was set up. But I really wanted to hear from you all at whatever point in the presentation, and I might have a different version from last week than what's on the screen about the from what you said there, Lexi, in regards to transparency about how y'all got where you were. I appreciate the acknowledgement that Boulder County Public Health has had some financial issues that has been using different system for quite a while. So I just want to make that clear for everybody. I don't know everybody on the screen, but for me, as one Board of County Commissioner member, it's important in our work with separate entities and all the partnership that we do, that we get to a place where we're all working together. And so I just want to appreciate all the work that's happened. And I know for my understanding from Board of Health members, that's been really important as well for you all to understand the finances so that you can make decisions, so that when Boulder County Public Health employees are going to you and asking for, how you're going to use the funding that's received, that everybody has the same information. So I'm really pleased that we're here now to move forward, but I would love to hear a little bit more. And again, if that's in the presentation elsewhere, that's great. But I just want to be clear that we've been having conversations for quite a while, and it wasn't just in the fall of 2023, but way before that, that as one county commissioner had shared concerns about the budget and where we were in regards to finances. And so appreciate all the work to get us here in the room again. So are there any specific issues that you would like to see addressed that I can speak to, or we can determine whether they're wrong? No? Okay. Thanks.
Yeah, I was gonna ask, but Marta did the right thing by asking me, just saying some preliminary things first about it. It's great to be here together and really come to an understanding of your budget and help us see how you're trying to present it to us. And I do appreciate the time you made available to walk through so we could ask some more specific questions than we might have time for here today, because there are a lot of things that are still just for me a little bit confusing. But you referred to the fund PH 13 and PH 11. What is PH 11?
So we have three appropriations. PH 11 is the public health appropriation. So PH 12 is where we put sustainability funds. And then PH 13 was newly created once I started. So I've been in my role not quite 2 years. And when I began, Aaron Pratt proposed to public health that we start tracking personnel in PH 13. So we started tracking personnel, but we were not tracking the operating that we were receiving from the county in that PH 13 appropriation. So that's the adjustment that this slide was making. We started taking some of those entries that would have been county funded But we moved them from PH 11, where we traditionally had held all of those operating expenses. And we moved them into the PH 13 if we deemed that it was truly county funding that was appropriately moved.
So does PH 11 still exist? You still
Yes.
use it?
Yes, we still use PH 11.
Thank you for having us. And we all met individually with Lexi and Desiree, and I really appreciate you taking extra time and answering these questions. Just for level setting for myself, the board has already gotten their questions answered about the budget and what was changed and everything, and that's why there are no questions from the Board of Health.
Yeah, so we have, I guess this presentation was shared with us last week, and then we have had monthly updates from the Office of Admin and Finance, so that the board, which really prioritized this conversation around adding transparency and understanding where there was misalignment, I think, and in the numbers, and I think you all have access to systems that we do not have access to as board members, right? So we couldn't see into Oracle the way that you can see into Oracle. So we've had, since this has all happened in the last year, the board really highly prioritized. We want to know why there's a misunderstanding here, or what's going on with the numbers. So admin and finance has been, we've had a standing agenda item on our board meetings every month since then. So we've been getting regular updates, and again, I mean, so much work I know went into bringing this over, and it's been a great learning opportunity for our board also, just to understand how the systems were different and having transparency for us. And we're really excited to be in better alignment, we hope, with the rest of the county in terms of we're all looking at the same numbers. So
Thank you. That helps me just understand like what we're all receiving and doing here today. So thank you for that and adding that. And also my thanks for prioritizing the alignment and just making sure we're all using the same set of figures and basis of accounting. It's great.
I might just add in there, and again, if this is in the presentation already, then we can, and it can also be a posted item, but I would love to hear from both Board of Health members and also from Boulder County Public Health leadership about just how your staff is doing. And I asked that because I had received a lot of questions in the ask of just evaluating the budget, getting everybody into the same system, making sure that everybody has the financial information, concerns about what does that mean for our programs currently and in the future. And so my hope is, and continues to be, and I've met with some of the employees in the staff meetings to just reassure the board that Board of County Commissioners will continue to support work at Boulder County Public Health. But I would love to, I'm always worried about staff and what the impacts might have when we have misinformation. I think what you were saying, like misalignment, et cetera. And so I would love to hear how you're working with Boulder County staff who are making asks I can just say to me about your decisions. And so I think this is there's always an opportunity to help folks understand that there really is a separate entity. And so we just want to put that on the post-it unless it's present.
No, I think that's a really important question. I mean, the way we've been managing the conversation with our staff is to be transparent with them about the need for us to do this work, the importance for us as an agency, as good governance and stewardship, and really sharing the history of how we got here in terms of kind of the move into spreadsheets and then not moving out of them quickly enough. Also providing context of, our budget's been more volatile than ever in history, I think, over the last few years in terms of ups and downs, and just the need to be really attentive to not just how we're managing this year's budget and to be able to do kind of much more attentive real-time reporting on budget to actuals, but also to be able to plan for the future as we, think about where do we need to be investing in relation to priority-based budgeting and strategic planning, and recognizing that there were some programmatic spending shifts that needed to happen. There were some spaces where we were overspending that we needed to tighten up on. So we tried to be really transparent with staff about that. And also what we were doing in terms of some of the system and structural changes, and our intention to look at the data when the books closed and when we felt we had verified numbers that we were submitting for the audit, and to make a decision at that point about whether to come back to the Board of County Commissioners at your invitation to return to look at the numbers to see if an amendment is appropriate. So we have been also, in a more practical sense, recognizing that this isn't our decision, it's your decision. We also been tightening up saving. We've been holding positions open if they weren't essential positions. We've put a pause on some of the training just to try to curb expenses until we had more clarity about the budget going forward.
Just a curiosity, but if the Board of Health members want to speak to questions that staff has been having around programming and planning and.
Yeah, so it's interesting that individual divisions might be coming to you asking about funding because they're not actually contacting us directly, asking about their programs and funding. I think as a board, we've tried to say to staff, you know, support you all. We appreciate the work you're doing. You know, we want to be stewards of this department and the great work that you're doing in the community. So I hope that staff has heard us try to iterate regularly how much we support the work that they're doing. And I guess I can't say that I have received a lot of direct communication from staff asking about specific programs.
Okay, same.
Yeah, I would just add, this is Lindy, that we actually, from a policy perspective as a board, we really rely on Lexi and the head of HR to let us know about any staff issues, things that we need to be aware of. So I would think that the two lines of communication on staff are directly Lexi and then Julia Larson, our head of HR.
Great. I hope that's helpful for Boulder County public health employees to hear that direction from your board. Thank you.
Okay. Just a quick check. Do you all want to go through all of the slides? Do you just want to hit on slides that have been updated? How would you like to use our time? Because I know that you've received the slides. Our Board of Health has received the slides. So we're happy to accommodate what's useful for you.
So we've all been through the slides as you sent them last week, but you've updated some of them.
There's one that's updated.
Okay. I don't feel like I need to go through them slide by slide.
Let's go ahead and do that. Right. Thank you.
I'll give just a little bit of input because my understanding is that there were some public that were involved in the previous conversation, and because the previous conversation around the budget specifically was also public information and there was news story about it. So my understanding is there are people here in the meeting virtually that are interested in. And so for me, from that standpoint, I do think you need to run through your slides just a little bit in case there's folks that are trying to connect the dots about how we move from spreadsheets into a system that we're all using and what that means for staff and programming. I feel like it's going to be helpful. And maybe it could be quicker version of it, but I do think.
So this is one of the slides that has an update on it. So
Are you getting the same?
Yeah, I can read through it. Oh, yeah, here.
Well, yeah, it's not showing.
Yeah.
Are you sharing your screen?
I'm not sharing my screen. We just need to stop sharing and reshare. Yeah.
Apologies.
Yep.
All right.
Thank you.
And is that slide deck in the Teams chat? Is that where that's accessible? Just to be able to read the details of the slide on the on screen.
It'll be provided after.
Yeah, we can provide it to you afterwards.
Okay.
So this was just an update. We updated our trial balance and the upper level number didn't update. So we just would give you the most recent.
Sorry, I need to get to that slide.
Perfect. So beautiful presentation, but numbers are correct. This general fund number is coming from
the report in Oracle, there's a couple different fund balance reports that we can now pull. So we've been working with Bob Lamb on that reporting. So you can see that upper level number has changed. So it's a little bit less what actually rolled over. There's probably some entries that were happening at the very end before we submitted. And the other restricted amount is staying the same. That is Tabor. It's some rent monies that we were asked to hold for legal. And then down below, you can see there's an assigned fund balance. So that's the amount in the 2024 budget that was going to be covering some of the reserves. So you can see the reserves at the start of 2024 is now updated to 20.4%. And then the 15% minimum, which is now under guidance from Board of Health, our target is 15 to 20%. The 15% minimum would be that $3.6 million amount, which gives us spendable reserves of 1.6 million. And we do have more detail. We have different components of our reserves. So if any clarification is needed later, we're happy to provide where those numbers are coming from.
Board of Health target, that's 15% is calculated off of what, and why did that number change?
So the number changed. The reason that number is changing is because that upper level change happened. So the Board of Health 15 to 20% is a set number that is calculated off of the 3-month expense number, the 3 months of expenses for the year for 2024. But it's the percentage.
And sorry, the screen went away. I'm just,
Yeah.
You're good. You're good.
Yes.
It just booted me out. I'm gonna try it.
So it's a calculation we do based on a quarter of expenses for 2024, and that's the standard calculation that's used.
So that top line, general fund number was revised, and so the 15%.
So there was flow
The
through.
top number was just the starting fund balance, correct?
That's right.
And so how does that change 3 months of operating expense? That's what I'm trying to track.
It just changed, changed the amount of the reserve that was after the subtractions from that general fund amount. It changed what the net amount was. The net percentage went down by, I think, 1% from 21.6 to 20.4.
The reserves, our calculation of the reserve percent is a calculation of the reserve amount over the budget. Is that right?
It's based on 3 months of expenses.
Does anyone else understand my question and can ask it differently?
I am open to all interpretations.
I think. So 3 months operating is what your target reserves are.
3 months is what we use as the base for this calculation.
So
Which is,
I think the question is that your operating expenses didn't change. So if you're basing your reserves off of your 3 months of operating expenses, that number should not change. Your targeted reserve should still be whatever 3 months of operating expenses.
it's a percentage of the operating. So this just reflects what percentage of the operating the number is. So the operating was 21.6% of that 3 month. And now since it's slightly reduced, it's only 20.4% of that 3 month reserve.
Maybe I could try, I understand what you're saying. So 3 months of operating.
Yes.
Do you keep that number the same all year?
Yes.
Because, right, so if you're keeping that number the same all year long, average is, I mean, I assume you're not changing it every month based upon your next month. So I think the question is, why would that change then?
It doesn't. That doesn't change. What changed was the percentage, the number that was available after you subtract restricted and the assigned funds. You can see that number got reduced. So the percentage of the 3 months got reduced as well.
I think I'm hearing you say two different metrics for setting your reserves. One is a board established target of 15 to 20%. And the other is 3 months of operating expenses.
So the 3 months of operating expenses is the number that you use to determine the percentage that we have available.
Oh, So that's still, I think, it doesn't explain. Number would change, the percentage number would change, I get that,
Yes, that's why.
but the actual dollar amount would not change.
The dollar amount changed because the trial balance amount changed, and so we had to reflect that here. So this is accurately showing what Oracle is showing, so that upper number level changed because the financials that we submitted to our auditors changed. And so this is showing the updated number as far as what our fund balance was at the end of 2023. Will be flowing into 2024.
Okay, just to back up a little bit, can I try to explain it in a
Sure. Okay, it's okay.
So, our general fund at the end of 2023 previously was 7.4 or so million, and it reduced to 7.1 million. Our restricted funds stayed the same. Our assigned funds stayed the same. The reserves, like the general fund, were reduced by about 300,000. And that percentage is a calculation of the reserves over the general fund. So 5.6 over a $26 million budget was 21.6, but 5.3 over a $26 million budget is only 20.4. Does that help? It doesn't help me.
I think what you're asking, Ashley, is what the difference is between 3.9 million and the 3.6. Is that why you're asking, why did that change if it's supposed to be 3 months
Yes.
consistently?
Yes. So, and where my question is going, just to like, why is this question even coming up like at all? So the amount of money that is not allocated to staffing currently or anything is the sum of the bottom two lines. And the Board of Health has set a reserve policy around 15%. And so if you say had something that was a big need, the Board of Health could make a policy that it was 12% or some other percent. So I'm just trying, the sum of those bottom two numbers is an important sum total for me. And I'm just trying to understand why I'm not understanding how you're meeting the Board of Health policy of 15% with that number change. Like if 15% of operating is 3.9 million, which I don't know if it is, I didn't look. You can find that out. Then it's 3.9 million. If 15% of your operating expenses is 3.6 million, then I don't know why it was 3.9 before. That's all I'm saying. And where my question is coming from is really about the total, the sum of the bottom two numbers together.
Right. No, I hear what you're saying. And forgive me for the last minute calculations here. So what you're saying is the 15% minimum should have stayed the same based on what the total of the amount was. So
That's what I think, but if it's not true, then
yeah, exactly. And so this was obviously a last minute change. So mistakes happen in last minute changes. And I calculated this based on what that 20% reserve was. So I should have calculated that probably based on what the remaining amount is in that 3 month of expenses. Yeah.
So if we were to correct this, so we may as well correct it in real time.
That's it. I vote no.
We will update it in the slides so you have the correct.
I think they need online.
Okay, so I don't want to do. Yeah, we got it. So
So I want to get to your sort of bigger question though, right, is whether or not the board could dip into the 15% reserves, right? Is that what you're asking?
I mean, if there are needs and priorities, I'm just trying to understand how much funding is actually available and like whose side of the line it is on.
Yeah, and so does that clarify for you that if it's 3.9, that's the 15% minimum that the board wants to hold, and then that lower the spendable reserves is what is being applied to our 24 budget?
I see that. I don't have enough information until I get the updated number, because if it is 3.9 and you're holding firm at needing to keep that to be able to ensure if there's up, then it changes that number from 1.6 to 1.3 on the fly, random number.
So I don't have enough information. It's just gonna track through all the way through the funding request for me, because it just changes what that number is.
Got it.
So I was just trying to understand that relationship of those two numbers.
Yes. So does that make sense that the spendable reserves is what we're carrying forward to apply to the 24? Reserve minimum is what we're holding in reserves. Does that make sense?
I don't know that that's what the rest of the presentation says, but
Okay.
that would make sense.
Okay.
Okay,
Let's go through it then.
so I think that this is the corrected numbers. Yeah, we good?
Refresh that. Did you
Yes.
change the slide?
Same. Hey,
Yeah.
Lexi. Hey, Lexi, before we move to the updated slide, could you just talk a little bit about the why behind the policy of 15%? Because I think that's also important for us to, because we had a robust discussion about what a standard public health reserve amount is to stay healthy as an organization. So could you address that as well? I don't want that to get lost in this discussion.
Thank you, Lindy. Public health had typically held reserves between 11-15% historically. And when some of this happened, we decided maybe we needed a more kind of formal agreement on where we should keep our reserve target. And as Catherine Palmer was digging into some of the research, she really identified a practice of 15-20%. That's actually lower than some public health departments keep that aren't part of the county, that are separate legal entities. And that was the recommendation from the right?
Yes.
GFOA. Thank you. And yeah, so that was proposed as a range to try to create a target so that we were being intentional about where we were trying to hold our budget reserves in the future, given some of the volatility of the budget, given some of the fiscal cliffs that we're facing soon, et cetera. So, yeah. Would the board like to chime in on what you saw as the value of?
Yeah,
No, I think it's important that we had a discussion for the Board of County Commissioners, if you weren't tuning in, which wouldn't be offended if you did not. That the policy discussion was exactly how Lexi laid it out, which is we wanted to know kind of what a standard was out in the market, what would be applicable in our case. And the research really supported that. I think we also, as a Board of Health, had a discussion about what we were comfortable with in terms of a reserve amount, so that if something untoward were to happen, we've had a lot of those experiences over the past few years, that we would be somewhat prepared to manage against that. And so I do want to just make sure that as we're thinking about this, that we understand that the reserves are there for a very explicit reason, and we want to make sure that they're healthy and that we could tap into them as needed.
Yeah, I think that's right. I think we talked about what good governance, we need to ensure that we have for this department. And
Just a question though, you 15-20%, what is the GFOA recommendation? I think we've used 15%, but I don't know if that's specific to county government versus health budgets or what.
Yeah, I think it's a target that's on any governmental agency. We're a little bit out of my depth right now, but my understanding from reading Catherine's research was that and maybe Desiree knows more, but it's a standard for any governmental agency, and the purpose of having Ramona would be great in this case.
I pulled up the GFOA.
Yeah.
They said I think 2 months of regular funding.
And it does depend on what type of fund you're talking about. Like we have, enterprise funds are 15% of regular operating, but a good standard is 3 months of operating expenses is, like I said, there's many different types of funds that have different things, but 3 months of operating. And, we actually fine tune it. We don't do 3 months of, 3 months of budget. We don't take 12 divided, we actually look at the prior year and go, okay, 3 months of operating actual expenses last year was X. And we leave it alone for the whole year and we look at it every year. We adjust at the end of the year. We don't do the, budgeting and, we don't do this with our reserves. We just fix it once a year unless we had a fund that was, oh my gosh, we're going negative. We need to really adjust. But yeah, very typical, 15% or 3 months.
And we understood from that discussion also that the county holds those reserve funds for every department that falls under the county. So one of the conversations we had also is need our own reserve funds, would we be eligible for county reserve funds? And then we really determined that we should have our own reserve funding. Is that right?
I would agree with that because we don't do it by department, we do it by fund. So our general fund, our fire mitigation fund, all the different funds have their own reserve. So yes, I would agree that you're your own fund.
Yeah.
You should have your own.
I think we chose a range too because 20% wasn't realistic, right? Like we wanted to sort of stage it over a few years at a realistic pace for having those reserves. So rather than saying a flat number, we chose range.
The other advantage is that because we're kind of moving to 3-year budgeting and trying to do more projecting out because of the volatility of the budgets, it allows us to plan, do we need to be stocking away some extra reserves right now in preparation for next year or the year after, which was directly a play in the situation. Yes.
I just had a question just for clarification. What was the policy or practice previous to this reboot of financial status? Just because I heard, it sounded like some of this was newer conversation. So when did you start looking at GFOA or other separate entity reserve conversations?
It's funny because Lexi and I just had this conversation too, where I said, I remember that we always had about somewhere in the 10 to 15% range when we would do our budget study sessions prior to Lexi's as ED, as someone who's been on the board now for several years. But we did not have a standing policy that set a minimum budget reserve. So.
And we may get to this, but so a question I had for Lexi, when we were going through these slides is, how is all the rest of your money accounted for here? You're setting, the reserve is based on your entire budget and you're only holding reserve funds out of the county appropriation?
No, our reserves are based on our entire budget.
Yeah, it's based on the entire budget, but you're budgeting that, you're not setting aside like 15% of the state per capita money and each grant fund, et cetera.
Yeah, it's all of it, of our entire budget.
Yes. Maybe my question doesn't make sense. You're using the county general fund appropriation to fund your reserve? No.
No, I think
we spent down
we spent down all of that funding. I do think, to your point too, Claire, we really can't hold on to grant funding, for instance. We can't set aside for a reserve. So one of the conversations that we also had in coming up with this policy is what are our revenue options for filling that reserve pool? And it's pretty narrow. So that's also one of the things we want to hear from the board about your expectations around funding. And I think what we heard from you is that there's an expectation that we spend down all of our funds from the county. And if that's not an expectation, that's good to know too, that if we underspent by a certain percentage, that would not be eligible to go into a reserve pool. If that's the case, we want to know that from the board.
And the policy's been different in the last 5 to 10 years, as I understand.
There's a complicated, we don't have one kind of funding that we give you, right? So if there's a sustainability grant, that funding is taxpayer money that has to be used for a sustainability project. So I think the answer is quite complicated to the seemingly straightforward question to ask. Like we also have requirements and responsibilities. And just to clarify from my position, I wasn't saying I don't support a reserve. I just want to make sure everyone's clear on that. I support having reserves. I support having 3 months operating expense. I believe the math on the slide is still wrong. And so just before we send it out, like the final, I would just make sure that that's the numbers we want to use.
Because like, I believe the sum of those two bottom numbers needs to total to the 5.3 number. And so
Let's not making corrections.
I don't think we should make corrections in real time, but like, and the reason
into it and then.
yeah, I think philosophically, and the only reason I asked the initial question is the total of that number feeds into some of my thinking on follow-up dollar amount asks. And that's the only reason I was asking about it, not because I didn't support reserves, just the total dollar amount matters for what the total dollar amount ask coming forward is.
Yes. Yeah, we will true that up for you. We wanted to give you the most updated information, and in doing so, we made it work.
Yeah, no, math on the fly. I'm okay at math, and math on the fly in presenting is so hard, and it always goes poorly.
So
We have to know the does total up now. I mean, the 5,309,254 plus the 3.9 million does equal the 1.49254.
Thank you for checking our math.
Yeah, it does total a lot more. You have to kind of zigzag.
You have to move around.
Right, because we're holding the 3.9 steady now, constant, which I think was actually.
This is the ugliest slide ever, and we would never have purposely given you the slide.
And we are determined to get it right.
We will get it right. So, yes. Any other questions on reserve or where we are policy wise or what our intentions are?
It sounds like we'll get an updated slide later.
You will.
Thank you.
Yeah. I think we can move to the next slide. We're on this side.
All right. So luckily, this slide is not affected at all
By what just happened.
by the previous slide. So what this slide shows is the various components of county general funds historically allocated to public health. It shows our original request in September 23. It reflects the funds that we received in December from the county and an assessment of our revised needs, which represents a decrease from our original ask of about 660,000. And that decrease is due to a couple of things. One thing is being able to plug in the actual salaries versus projected kind of salary holds. You know, in the fall, we don't know what the COLA and merit will be. So we put estimates in alignment with OFM. And those came down a little bit. So that helps save some money. It also reflects some pay equity adjustments for our staff. And it reflects taking out the OWTS fee subsidies because we have now internalized the costs of that program. And so just to go line by line, that was mostly related to, and it also, you'll see kind of a rebalance of the operating and the salary general funds. And that's because we had some funds in our operating fund that were historically put aside for salaries for our OASIS program. And it didn't make sense to keep holding it in operating. So we shifted them over to the salaries. So that's where you're seeing that kind of difference between the original ask and the amended request. Our Genesis fund was part of the general funds, so we did not receive any of those funds. And the HHS B1A was reduced by a little over 100,000. We are requesting to go back to the previous year's allocation, which would be an increase of what we received of about $35,000. So that takes us to an amendment request of 1.880 million.
So the revised need is what you were just speaking to. The numbers don't line up from what I was listening to. The revised need is what you're, after you looked at all of that data, it's the totals. And so that's how you're getting to the amendment request. Is that what I'm?
That's right.
Okay. I mean, one of the questions because I'm looking at the clock too, so I know we'll have to accept some non-closure here. But I am curious because some of the questions that have come to me as a board
commissioner and not a Board of Health person, and it sounds like you maybe have received some of these questions. I just want to share those for you all to think about. Some of the questions that have come to me in a variety of different methods is, what is Board of Health? Where's the focus in regards to equity work for Boulder County Public Health? And so I've just directed folks to talk to you at Board of Health, because you all get to make the decisions about how you want to use your funding. So I just want to share that when I'm looking at specific programs on here. And you probably are talking about that in your retreat in just regards to where your priorities are and the work that you're doing. And I know you were talking about your 3-year plan, but I just want to share that with the board members who are here.
Great, yes. So health and racial equity is one of our strategic priorities, and we plan, public health, I think, probably has a pretty strong through line of equity across our initiatives. We can give you lots of examples, but what part of what we would like to do is to continue to participate in a priority-based budgeting process, and to be able to highlight some of that work as we go forward.
You have 15 minutes left.
Okay, thank you.
And we are participating in the county budgeting for equity. Great. Thank you. Yeah, we're excited about that initiative. So we can still get that in motion.
Okay.
Did the Board of Health have any conversation about the spendable reserve? And would you spend it? Would you think it was a good use of funds to spend it on any of the gap? Is that a conversation you all have had?
So, yeah, so you're asking about the carry forward that was on the previous slide that I said is being applied to the 24 budget already.
No,
the
additional.
You're wondering about that 15%, whether or not we would dip into it?
No.
Okay.
The amount of reserve, so there's like 7.5 million in reserve, and there's some amount between 1.5 and $2 million.
Yeah, we have one
that is above the 15% reserve, depending on what the 15% reserve is. Was our conversation about if the Board of Health thought using any of that funding was a good way to close some of that gap? And if you haven't had that conversation, that's fine too. I just wondered if that was a discussion.
It just for clarity, the 7.1 is our general fund. It's not our reserves.
Yeah.
Yeah.
There was starting fund balance.
Right.
In general fund 7.1.
Right.
So and I'm just asking about the somewhere between 1.5 and $2 million that's in excess of your minimum. If there was a discussion about using some of that funding to close this gap or not.
So that is the connection to the 3-year projections on the next slide. Because we were trying to hold additional reserves to spend in 25 and 26, given the fiscal flexibility.
Okay, I understand that. So, and I wonder if there was a discussion about using that for this gap or not.
I don't think there has been yet.
Okay.
So this chart details the 3-year spending plan, and it challenges our previously secured reserves and the challenges that we were intending to address with kind of building up those reserves. We would only need to reduce 1 FTE this year. Though, we may make some decisions based on priority-based budgeting if the amendment went through. If the amendment did not go through, we would need to reduce much more significantly. And when we look at 25 and 26 with some of the committed funds that we would need to make, some of the assigned funds that we would need to make, and then to bring it back up to 15%, you can see that, we would continue to need to step down some of the staffing. And some of that is not surprising. We still have a little more staffing than we did before the pandemic, but we also have, for instance, Family Connects is a program that is really a new staffing group. So it's, we have also grown since before the pandemic in terms of programs that are important. So what you see is that we can kind of manage we can kind of use our reserves strategically over the next 2 years to manage some of those funding shortfalls. But we will be more pressed without the amendment.
So the slides we got showed 0 positions to reduce in 2024. You've got 1 up there. I can't read all those other numbers. What?
Right, so that's just because of the update that we just made.
Oh, you just did that. Okay.
So I wonder, thanks for the update here. 2 things. One, the Family Connects program that you just mentioned is a COVID relief, American Rescue Plan Act funded. So we knew that was going to be a temporary program. So I just want to say that in the conversation.
Yes, that's
for
correct.
any board members who maybe joins in.
Or we had to look for our own sustainable funds to continue it.
Correct. So, but that was very clear.
Correct, absolutely.
And the receipt of $63.3 million at the county level, and then looking for different partners like you as a separate entity to how could we transform lives with COVID funding. And I just want to be clear that that was one that we knew was going to be a temporary situation unless, like you said, Lexi, found some sustainable funding. And I wondered if you could talk about the 3-year plan that you all had shared with us last year that you were starting to put together, that you were looking for other grant funding, that you stated that at some point Boulder County wouldn't be the biggest funder potentially of Boulder County Public Health, and just looking at some other opportunities, because it was clear then that there was positions that were going to be reduced, not just from the step down of ARPA, because again, there were so many different temporary hires with that understanding that if sustainable funding didn't happen, they wouldn't be beyond. So I just want to be a little bit clearer about that in regards to the way this is set up with an amendment and without an amendment. My understanding from Boulder County Public Health was that there would either way and anyway, there would be a plan to reduce staffing.
Or to find additional funds. And we have been successful in securing some additional funds for that program.
Right.
Through the state legislature has allocated funds for it. So that actually isn't reflected so much in these numbers as the problem.
And what other funding are you working on in regards to just staffing in general for the amount of staff that you have?
I'm happy to provide a list of kind of where we are at this point. We are continuing to look into Medicaid funding. We continue to submit a lot of grants, particularly in the MBH space. But I'm happy to provide you a specific list.
For me, that would be interesting just because this, to me, paints a very bleak picture, and it puts it like the county is the onus of fixing a situation, when my belief, based on what y'all have shared, is that there's actually all this grant funding that you just talked about. There's a position that might be doing grant work since last year to alleviate some of that. So I just want to make sure that we're sharing all of the information at the same time.
Thanks.
I want to thank Desiree a ton and Lexi a ton for working through all of this and being able to have this transparency and having the numbers match. And I think there's a tremendous amount of work that's gone into the last, 6 months or however long to get to this point, which is very cool that we can actually have productive conversations and have this kind of conversation. So I'm incredibly grateful. I guess rather than categorizing it with an adjective, I just think it does show, regardless of an amendment or not an amendment, like a declining revenue, right? If you look at with amendment or without amendment, what year-end reserves are, and I assume you just carry forward. If you say in the with amendment version, you carried forward some kind of that level of funding plus 3% or something like that into your other 2 years. And then without, you just carried forward that level of funding without for 3 years.
So the numbers are based on our current reserves level. Recognizing that we are still right sizing some of our programs that had deficits this year.
Yeah, so my question I was trying to say or throw in there was around what you put in on the revenue side in 2025 and 2026. Because I really see a 2025 issue, and I'm not trying to
make anyone feel any particular way. I am struggling to see the 2024 issue still with all of the information. I do see the 2025 issue and the 2025 budget conversation. And I'm just having a harder time seeing the 2024 issue.
Well, so I think the 24 issue is that by the end of the year, our reserves would be at 7.4%.
5 minutes left.
Does that make sense?
Not really. I don't track that with the previous, if the information in the previous slides is what I understand it to be.
The beginning reserves includes the spendable reserves as well as the rest of the 15%.
May I ask a question, Lexi? So in your 2024 modeling, are you spending down some of that spendable reserve already? You see what I'm trying to ask you?
Yeah, that
Is there spend down of the spendable reserve?
That 1.5 is what we would make into our assigned funds for next year. It would take us just at that 15% level.
Which is where you technically need to be based on the 15%.
I think that's what I was trying to say is that we're applying that leftover, that difference between the 5.3 and the 15%, that number you were asking about, the 1.6 million, applying it here to the 24 budget.
I don't think that's what I hear Lexi saying that you're doing.
Yep. Okay, let's try again. We can get this.
So I guess which program are you spending that funding on?
It's a variety. I mean, this is information we can supply you with too, but it's a variety of programs that just are not, don't have the revenue coming in that they would need. And some of them we're okay with thinking about making reductions in, and some of them I think are really priorities for achieving our strategic goals over the next few years. But I can provide you with more detail if that's what would be helpful.
I don't know if it would help the entire group.
Well, I do want to make sure I'm understanding, regardless of exactly what you're spending that spendable reserve on, that the figures in the 3-year budget projection, if that you're using those monies, they're not still in reserve, that this beginning reserve balance, which is now, I don't have those numbers here, but that's updated. And somewhere that 1.5, whatever the number is already plugged in and being spent. It's not continuing to be.
We have assigned it to next year's, we're assigning it to next year's
In
budget.
2025.
That's right.
Right, which is why I think it's a 2025 issue.
And when you assigned 1.7 million from 2023 to 2024, as you and I discussed, you were using that money to pay expenses that you knew were accruing. You're spending them in your budget.
Can you clarify a little bit about what you mean with the?
I'm trying to understand what you're, I don't know. I'm trying to understand what you mean when you're talking about assigning money to a future year.
When we begin to write, or correct me if I'm wrong, when we begin to develop our 25 budget, we begin to see where we're going to have deficits and whether those deficits are important for us to spend reserves on, or if we're going to make staffing changes. And so we have to assign them when we go to the Board of Health in August to pass a balanced budget. We have to have already assigned them in 24 for the next year to make the 25 proposal a balanced budget.
So $1.7 million from 2023 is already in your 2024 budget, and the 1.5 or 6
will be budget that we're working on now. Pending priority-based budgeting.
I just have one question, and unfortunately I have to leave at our end time at 4:30. Can you speak about the vacancies and where that is? this budget and the numbers. On the 7th slide, there are vacancies named there, so I'm just trying to figure out how that plays into the numbers.
Which slide?
Oh, it's 7 of 9 on the version that you gave me last week. So there's notes on the bottom that talk about current vacancies.
Oh, we only have one current vacancy that's county funded. We have a few additional ones that we've been holding across the rest of the organization until we had clarity on the budget and what we were working with. But we also did a lot of work with HR at the beginning of the year to Ramona, help me describe this as we talked about. HR doesn't have position control over our positions. And so what had been happening, and the reason that Ashley was seeing so many vacancies in that space was because there were positions that we used to have that we weren't intending to fill, but they were kind of placeholders just in case we ever wanted to use that number again. And so we went through and they developed a process for identifying like what's an active vacancy versus what's an inactive vacancy. And once we did that, it came down to like, I think we had 7 vacancies at the beginning of the year.
So none of the vacancies, in our slides, it shows 2 county and then some other vacancies, but none of those vacancies are in your budget.
Well, no, they are in the budget if we intend to refill them. I mean, the county funded positions, one is our director of admin and finance, which we have to refill.
Yeah.
And I'm trying to remember what the other one was. I think it was that one that just got filled in environmental health.
Yeah, it wasn't.
We can provide some additional information on the current vacancies.
Thank you, and I apologize, I have an in-person appointment. Thank you, everybody. Thank you.
I think the thing that would help advance the conversation, maybe at the table, is to show what amount of county revenue you have in each associated year in the with and without amendment columns. I think that would be helpful. Okay, good. And Ramona, do we transfer the whole amount over January 1st? Like, how do we, if we have
Transfer what amount?
if we have a general fund allocation?
That's
So
what
it's on
you-
January 1st. Yeah.
Well, maybe not January. but
January
first-
2nd.
First January.
We submitted.
And then
To the
once it
budget.
gets approved, so
Yeah.
a week or something.
Right.
Yeah.
Yeah, it hasn't been that early. I mean, I've seen it happen very late in the year, but yes, the intention is to be there.
Yeah, we changed our policy, all, not just you, all transfers are now happening in January, so everybody knows what their budgets are and we can overspend, those type of things. So, yeah, January. I can't commit to January 2nd.
We might not be back yet.
But yes, January.
And I think I just have one other question, and I think just for our purposes, it's nice to have all 3 of us here, so we all get the same information. So, and I had a 4:30 call that I'll do a little bit late, but, you have talked over the last, 12 months, 18 months, about re-examining some of your programs and services, and that you do think that there are some that you intend to reduce, that you don't think they're really serving, they're not efficient or they're not serving enough people. This projection of positions that you would need to reduce, does it reflect that work?
It does incorporate a lot of it. Yeah.
And so the reductions in whatever the programs, I don't think I know exactly which ones they are, but
That's what we're going to be figuring out through the priority-based budgeting.
I thought you had already identified sort of in your mind some things that you knew that you wanted to address. Not through priority, this precedes priority-based budgeting.
So we had some spaces we were looking into, but we haven't made any decisions.
Well, we really appreciate your time and your thoughtful questions and conversation and your consideration of the member request. And if there are other questions that you all have, it sounds like we're all taking notes on a couple of follow-up questions. But if there are additional questions that we can answer.
And we have a
don't
list.
hesitate. Yeah, and again, really appreciate just the conversation and the process, which has not been an easy one over the last few months, mostly for the staff. But I think for our board, it has been a really important exercise. So just really want to get into greater alignment with you all too on budget conversation. So it's been a really important exercise for us.
Yeah, thanks.
Thank you to the board members for volunteering and putting all the effort and heart and soul into the community. It's a ton of work for a volunteer position, and we're really lucky to have such intelligent, capable community members that step forward. So that it's really tremendous. And just, I want to reiterate, Desiree and Lexi, thank you for working through this and getting everything to match up. Like it's a lot of work, and it'll make figuring out what to do going forward much easier. We're all on the same page.
We're thrilled about that particular outcome of this process. It was a daunting task, and I think the sooner we got it done, the better. So we're actually really excited about having a really strong system at this point. So.
And no more spreadsheets. We're all very excited about that.
Great system. Yeah, it's pretty cool.
And my thanks as well for all the work that's gone into this and your availability, your openness to just answer questions. We'll go back and we'll discuss, and we may have some more questions, and you'll send us the. We'll have that. Thanks.
Thank you so much.
There you go. Thank you. Thanks, Ramona, for all your support too.
Oh, Ramona, thank you.
Oh, it's sorry.
Thank you, Jana. That's for your support today. You said it before, but we'll say it again.
So. Hey, Joe. So yeah, all these make staff, if you would exit, the board will vote in printing session. We'll turn everything down, and then we'll get the new.
So we need to vote now,
Yes.
and sorry, to send in the language for the pursuant to Kate, maybe you. Top of your head.
There's You have it, Kate?
I
know. Okay, try to look.
Yeah, I might be like, yeah, no, I got it. No worries. Yeah, always. Thanks, Joe. Thank you.
It's not.
So many emails.
Okay, I got it.
Okay, you got it. Thank you. Okay. Okay, thank you. Okay, so.
It's this person.
Yeah. Okay, so,
It's of the exec session.
yes. Board of Health members, I need you to be present here. For the purpose, we are going to enter into executive session, purpose of the meeting to consider personnel matters pursuant to Colorado statute 24-6-4024F. And I need a motion, please.
Motion to go to executive session.
I second.
Thanks, Brooke. Great. Thank you. All in favor? Aye.
Aye.
Thank you. All right, we will see you on the next Teams meeting. All right, so. Stop recording.